This conference will now be recorded.
So today we will be discussing this 2017 talk, Management of Diabetic Ketoacidosis in Pregnancy. This is very important talk because you have a nice guideline on diabetes mellitus in pregnancy, but they have not mentioned anything on this diabetic ketoacidosis. And usually you get question, even in the recent exam also there was one question, I suppose. Okay, so we will discuss. Actually, there is nothing much that the flow chart for the management part that you should know. It's very important. Okay, so we will come to it. So diabetic ketoacidosis in pregnancy, it is a very serious complication. The pathophysiology of this diabetic ketoacidosis in pregnancy, the things you should remember is it is either relative or absolute insulin deficiency, and because of that there will be simultaneous increase in the counter-regulatory hormones. So what are these counter-regulatory hormones are? Catecholamines, glucagon, cortisol, and growth hormone. Okay, and it will lead to various metabolic disturbances. So these metabolic disturbances, if you know, then you will know exactly what is the what are the exact electrolyte changes will occur in this diabetic ketoacidosis. So the things which increase in this diabetic ketoacidosis is increase in lipolysis, proteolysis. Okay, so lipid breakup will be there, protein breakup will be there, gluconeogenesis will be there, glycogenolysis will be there. So this gluconeogenesis and glycogenolysis, this will cause increase in the blood sugar levels. Along with also there is decrease in peripheral glucose uptake. So all these three mechanisms contributes for the increase in blood sugar levels. Then lipolysis, it will cause increase in the free fatty acids, which will responsible for this ketoacidosis. Okay, so increased production of ketones and it will lead to ketoacidosis. So these are the basically metabolic disturbances that occurs in the diabetic ketoacidosis. So what are these? That is lipolysis, proteolysis, gluconeogenesis, and glycogenolysis. So these are the four major disturbances. Now this diabetic ketoacidosis usually found in type 1 diabetes mellitus, but it can be also there in type 2 or in gestational diabetes mellitus also. Now, what happens? Why this diabetic ketoacidosis is increased in pregnancy? So, as you know, pregnancy is a state of respiratory alkalosis. Okay, so there will be a drop, compensatory bicarbonate level decrease. Okay, so because of this decrease in bicarbonate levels, there will be impaired buffering. Okay, so buffering capacity will be impaired, and that is important factor that renders this woman more prone to develop diabetic ketoacidosis. Also, there will be relative insulin resistance. So, pregnancy is a state of insulin resistance. Also, there will be enhanced lipolysis. So, because of insulin resistance, there will be increased blood sugar levels. Because of enhanced lipolysis, there will be elevated free fatty acids that will cause the ketoacid production. Then also the hormone changes which are occurs in pregnancy, like increased level in progesterone, human placental lactogen, and steroid levels. These all will responsible for the decrease insulin sensitivity or increase insulin resistance. So it will also contribute for the increased blood sugar levels. So as I told you, it is usually present in type 1 diabetes, but it is also there with type 2 and gestational diabetes also. What are the precipitating factors for diabetic ketoacidosis in pregnancy? So these are protracted vomiting, hyperemesis, infection, insulin non-compliance, medications precipitating diabetic ketoacidosis like steroids, okay, or anything that will like tocolysis, beta mimetic. This will also increase the incidence of diabetic ketoacidosis. Also insulin pump failure and conditions like gastroparesis. So these are the things which are responsible for this diabetic ketoacidosis in pregnancy. What are the signs and symptoms? So signs and symptoms can be very subtle or it can be very severe also. So it ranges from nausea, vomiting, pain in abdomen, polyuria, polydipsia, blood vision, muscle weakness, drowsiness, lethargy. So all these are normal signs symptoms of pregnancy also. But along with that, you can sometimes you get very severe symptoms like hypotension, tachycardia, coma, and shock also, and it will lead to abnormal fetal heart pressing. Also, there will be hyperventilation, that is small breathing or teardrop odor to the breathing. Okay, so this is because of ketoacidosis. This is the important thing. That is, what is the diagnostic criteria for diabetic ketoacidosis in pregnancy? So there was a question this time, I think, for this ketone levels. Okay, so blood ketone levels more than or equal to 3 millimole per liter. So this, I think they have given like values from 330, and they have given also millimole and nanomole also. So the unit also you should remember, and level also you should remember. So blood ketone more than 3 millimole per liter, blood glucose more than 11 millimole per liter. Now in India we are used to this milligram per dl, correct? Sugar values milligram per dl we are used to, and we usually get confused with this millimole. So just remember this multiplying factor, it is 18. Okay, it is 18. So converting factor is 18. So 11 into 18, it becomes almost 200, 198. So it becomes 198 or 200. So blood glucose more than 200, that you should remember. And in millimoles, it comes as 11 millimole per liter. Bicarbonate level less than 15 millimole per liter. Okay, so bicarbonate level less than 15 millimole per liter, or venous pH less than 7.3. What are the investigations that you should do in diabetic ketoacidosis is that serum or urine ketone levels. So urine ketones, it is 2 plus or more, or serum ketones more than 3 millimole per liter. Then also hyperglycemia, that is sugar levels more than 11 millimole, but DKP can occur at lower glucose levels also. Low serum bicarbonate, that is less than 15, arterial pH less than 7.3, and 9 graph more than 12, elevated breast deficit more than or equal to 4, and potassium level, these will be usually falsely normal or elevated. So it is hypokalemia, but they are falsely normal or elevated. Now, management of diabetic ketoacidosis in pregnancy. So these are the basic principles that are to be followed while managing this diabetic ketoacidosis. So usually this DKP is treated in level 2 critical care units like HDU or intensive care units. So level 2 critical care is required, and the basis of management is IV fluid therapy, IV insulin, electrolyte correction, evaluation for the need of bicarbonate administration, identification and treatment of any precipitating factors like infection or any tocolysis if you are giving any steroids, and monitoring of maternal and fetal responses. So now this is the thing, basically see, this is the chart they have given in the talk. Okay, and whole your talk depends upon this remembering of, you have to remember these charts. Okay, so I have just divided the charts in the following this thing so that you can remember it very well. So regarding IV fluid management, the choice of fluid is 0.9% normal saline. So choice of fluid for DKP is 0.9% normal saline, that you should remember. Now the rate of infusion in the first hour, it is 10 to 15 ml per kg per hour. And then it is adjusted according to hemodynamic status. So hemodynamic status means you have to follow the BP and the urine output. Okay. And depending upon that, then you have to adjust the fluid rate. So what is the arbitrary fluid management should be given for a patient around 70 kg? So you have to give 0.9% normal saline, 1 liter in 1 hour, the next 500 ml in next 4 hours, then 500 ml per hour in into 4 hours, then 250 ml per hour into 8 hours, and then finally maintenance will be 150 ml per hour. Okay, so first you have to halve the rate. Okay, every time you have to half the rate. So first hour you have to give 1 liter per hour, then next 4 hours you have to just half it, it is 500 ml per hour. Again for next 8 hours you have to again half it, that is 250 ml per hour, and then maintenance dose will be 150 ml per hour. Now when the blood glucose falls below 14, that is 250 milligram per dl. So when the blood glucose they are less than 14, you have to add 10% dextrose, 125 ml per hour. Okay, so initial choice of fluid is 0.9% normal saline till the sugar comes to less than 250 ml. Okay, and once this sugar comes to less than 250 or 14 millimole, then you have to add 10% dextrose, 125 ml per hour. Now insulin and potassium. These are the values that you should remember very well. insulin replacement will depend upon the potassium levels. So these are the potassium levels that you should remember. So it is 3.3 and 5.5 that you have to remember. Okay, what you have to remember is 3.3 and 5.5. So less than 3.3, that is 3.3, you have to give only potassium. So that means in hypokalemia, you have to give only potassium, no need to give insulin. Okay. So just you have to give potassium 40 millimole per liter of the ongoing IV fluid. If potassium is still less than 3.5, you have to take a medical staff review, that is medicine review, and switch to IV insulin when the potassium is corrected. Now, when the potassium levels are between 3.3 to 5.5, that is 3.3 to 5.5, you have to give both potassium and insulin. And when the potassium is more than 5.5, no need to give potassium, but give only IV insulin. Now, potassium dose, I told you, that is 40 millimole per liter. And insulin, the dose, what you have to remember is 0.1 unit per kg per hour. So it is a fixed rate infusion, 0.1 unit per kg per hour. And it has to be increased by 1 unit per hour if the targets are not achieved. So we will come to that targets later on. Once you have started the first dose of subcutaneous insulin, that is sugars are coming normal and the patient has improved. Once you start the subcutaneous insulin dose, then you have to start the IV, you have to stop the IV insulin 30 to 60 minutes after the starting subcutaneous dose. Okay. Third thing is identification and treatment of the cause. That means you have to find out any precipitating factors depending upon the investigation, that is complete blood counts, urine analysis and cultures. If there is infection, if there is any tocolysis going on, if there is any corticosteroid therapy going on, if the protracted vomiting is there, hyperemesis is there. So you have to find out the identifying cause and correct it. Fourth is patient monitoring. So patient monitoring is very important in this DKA. So first is hourly blood glucose level until they are stable, blood ketone levels hourly initially and then 2 hourly. Electrolytes, blood urea nitrogen, creatinine and NSPH every 2 hours until the patient is stable. So these are the monitoring that you should remember. So here it is hourly glucose levels, hourly ketone levels, and 2 hourly it is electrolytes, creatinine, blood urea nitrogen, and NSPH. And fetal monitoring, you have to first confirm fetal viability. You have to see the fetal heart rate. Then you have to do the CTG monitoring, ultrasound if it is required, and if there are any precipitating factors or if there are any indications to deliver the baby, you have to deliver. This is the basically monitoring, monitor blood pressure, urine output, and also central venous pressure depending upon the seriousness of the patient. Continue the basal insulin. If the patient is on glargine or detamir insulin, you have to continue that. Metabolic targets, that is what is important while maintaining the treatment. You have to see whether these targets are achieved or not. So ketone level should decrease by 0.5 millimole per hour. Bicarbonate should improve by 3 millimole per hour, and glucose should decrease by 3 millimole per hour. Okay. So glucose decrease by 3 millimole per hour, ketone decrease by 0.5 millimole, and bicarbonate should improve by 3 millimole per hour. And when you will tell that completely DKA is completely resolated or it is completely treated. So when the blood ketone levels are less than 0.6, pH more than 7.3, bicarbonate more than 15, and anion gap is less than or equal to 12. So these are known as the DKA resolution criteria. So please remember these values. Okay, in this DKA, this is the only thing. This flow chart is the only thing that you should remember. And after 6 hours of treatment, bicarbonate is not a reliable indicator. I will come to that why it is not used for monitoring of this DKA patient after 6 hours. Okay, so after 6 hours, bicarbonate level should not be used for monitoring. So this is the whole flow chart. Now, usually what happens in DKA is whole body phosphate is decreased, but replacement is not recommended unless it falls less than 0.32 millimole per liter, or if the patient develops cardiac impairment or respiratory depression, because it gets normalized when you normalize the sugar levels and potassium. So phosphate replacement is not recommended unless it falls below critical level of 0.32. Also, bicarbonate replacement is also not recommended. Why? If you give bicarbonate externally, what happens? It will inhibit the compensatory hyperventilation, and this hyperventilation is necessary to wash out the carbon dioxide. Okay, if this carbon dioxide is not washed out, it may result in decreased oxygenation of the fetus and fetal hypoxia. So this washout of carbon dioxide is necessary, and if you give bicarbonate externally, it will inhibit this washout. Also, this bicarbonate, if you supply externally, the patient may develop paradoxical cerebral acidosis, because this CO2, it diffuses through blood-brain barrier and it causes cerebral acidosis. Also, it delays the washout of ketones. Okay, bicarbonate also delays the washout of ketones and it worsens hypokalemia. So, bicarbonate infusion is not recommended. Phosphate infusion or phosphate replacement is not recommended. So, what is the recommended replacement is only insulin and potassium. Okay, these are the basic mainstay and IV fluids. These three are the basic mainstay of the treatment. Now, why bicarbonate should not be used after 6 hours? So what happens when you start giving sodium chloride? Okay, that is normal saline. When you start giving normal saline, it results in hyperchloremic acidosis, okay, which is there with normal anion gap and it decreases bicarbonate level. So this hyperchloremic acidosis is different to that of this diabetic ketoacidosis. These two are totally different entities. What happens in diabetic ketoacidosis is there is increased production of ketoacidosis, and this bicarbonate, these are utilized to neutralize this ketoacids. So therefore this bicarbonate will be lower. Okay, bicarbonate will be lower in diabetic ketoacidosis because these bicarbonates are used to neutralize the ketoacids. While what happens in hyperchloremic acidosis is, as you give a large volume of normal saline, it will cause dilution. Okay, and because of this dilution, there will be lower plasma bicarbonate. Okay, and increased chloride because you are giving normal saline or sodium chloride. So there will be increase in the chloride level, and because of dilution, there will be low bicarbonate. So there will be metabolic acidosis finally. So these two are totally different entities. And here basically what you have to do in diabetic ketoacidosis, you have to decrease the production of ketoacids. So that's why you are giving the insulin to stop that lipolysis or free fatty acid production. While this hyperchloremic acidosis, it gets corrected automatically. It doesn't require any intervention. So insulin infusion, it has no role in the management of hyperchloremic acidosis. It is corrected by the kidney on its own. Now, while monitoring, if this ketone meter is not available, the anion gap should be calculated. And anion gap, how to calculate this anion gap? That is, you have to measure the positive ions and you have to subtract it negative ions from that. So positive ions in the body measure are sodium and potassium. So you have to measure the sodium and potassium concentration. You have to add it, and from that you have to subtract chloride and bicarbonate. So sodium plus potassium minus chloride plus bicarbonate. So this is the way that you will calculate the anion gap. Now arterial pH measurement is not required. You can just measure venous pH, that is sufficient. And you have to remember that, yes, even if the blood ketone levels falls, blood ketone levels. So for the resolution, what you have to measure is blood ketone levels and not urine ketone levels, because this ketonuria, it will persist for a longer time. So to see the resolution or to see the response to the treatment, you have to measure the blood ketone levels and not urine ketones, because this ketonuria will persist for a significant time. Now, what happens to the baby in case of DKA? So, in case of diabetes ketoacidosis, the fetal mortality rate is 9 to 36%. Okay. So, fetal mortality rate in case of diabetic ketoacidosis is 9 to 36%. And along with that, the morbidity is also higher. Perinatal morbidity is also higher, and the complications are mainly due to this hypoxia related complications. Because as I told you, this carbon dioxide get diffused through the blood-brain barrier and it causes fetal hypoxia. and also this serum ketone levels, that is 3-beta hydroxybutyric acid. So these are the serum keto acids, and lactate. These are also harmful to the baby. Also, because it causes decreased glucose uptake by the fetal brain, and it will again responsible for the fetal brain hypoxia. How you're going to monitor the fetus? So what happens with the baby is, because there will be severe metabolic disturbances or electrolyte disturbances in case of DKA, it may cause maternal cardiac arrhythmias, but along that it will also cause fetal cardiac arrhythmias, which may result in fetal death also. Okay, and also the CTG usually it gives you the picture of acidosis, fetal acidosis. Usually this is corrected with maternal hydration and correction of metabolic acidosis, but the normalization of fetal heart racing, it requires 4 to 8 hours. This is also a SBA. So how much time it takes to normalization of fetal heart rate? So it usually takes 4 to 8 hours. Now, how you have to decide whether to deliver the baby or whether to monitor it. So decision to deliver, it should be individualized. It should be taken with the multidisciplinary team opinion, and it depends upon the various factors like maternal clinical status, fetal gestational age, and fetal investigations like fetal heart tracing and ultrasound. So all these factors should be taken account if you want to deliver the baby. Now, once this diabetic ketoacidosis is resolved, when there is complete resolution of this DKA, you have to educate the patient to avoid further episodes of this DKP and increase surveillance. That means repeated monitoring is required, adequate diabetic control is required, okay, to avoid this further episodes of DKP. Also, there should be increased fetal surveillance also, but this frequency of fetal monitoring is unknown and there are no guidelines. But you have to educate the patient regarding the frequent fetal monitoring also. Now, this is another one entity which is known as euglycemic diabetic ketoacidosis. So here it is a rare situation where the patient presents with either normal or below normal sugar levels. Okay, but the presentation is of diabetic ketoacidosis. Again, it is same. It can occur in type 1. So it is usually more common in type 1, but it can occur in type 2 also and gestational diabetes also. So why the sugar levels are normal or below normal in case of this diabetic ketoacidosis? So either this glucose is utilized by the fetoplacental unit with decreased maternal glycogenolysis and gluconeogenesis. So the baby utilizes the sugar so that mother sugar levels are normal, or it might be because of increased renal loss of glucose, because there will be increased blood flow to the renal. Okay, so because increased renal blood flow, increased renal loss of glucose, also there can be increased maternal use of glucose because of this estrogen progesterone levels increased. Dilutional effect, that is because of increased plasma volume, there will be decreased blood glucose levels, and also starvation, it can result with increased ketone production and depletion of the glycogen stores. So these are the all reasons for this euglycemic diabetic ketoacidosis. Now, what is the management of this euglycemic diabetic ketoacidosis? It is the same principle as that of DKP, but only thing here, so that means you are going to give insulin, you are going to give IV fluids, you are going to give potassium. So all the management remains the same. Only thing you have to add to the IV fluids is 5% dextrose with a separate IV line. Okay, so 5% dextrose with normal saline in a separate line from the start of the treatment to avoid hypoglycemia. Because you have to give insulin because you want to reduce this production of keto acids. So along with insulin, to avoid hypoglycemia, you have to add 5% dextrose also. Now, how you are going to prevent this diabetic ketoacidosis in pregnancy? So first important thing is pre-pregnancy counseling. Okay, so pre-pregnancy counseling, you have to educate the patient regarding the diabetic control, the importance of diet, exercise, and regular monitoring. And in the self-monitoring, glucometer and ketone meter. So in case of type 1 diabetes, also ketone monitoring is also important. So in the pre-pregnancy period, you have to give pre-pregnancy counseling, educate the patient, and also motivate her for the self-monitoring. Now, during pregnancy, it is the multidisciplinary team monitoring where you have to take help of diabetic nurse, diabetic specialist, dietitian, general practitioner. So all these things, they people should be involved in the management of diabetic patient. Screening. So you have to timely screen the patient at risk of diabetes mellitus or GDM. Education, as I told you, regarding the diet and exercise, and also regarding self-monitoring. And you have to diagnose the suspected DKP. Okay, because as I told you, the manifestations can be very subtle or can be very serious. Okay, the signs and symptoms. So you have to identify the patients and you have to do the necessary investigations. Now, what happens sometimes with these diabetic patients, usually in pregnancy, corticosteroids are given for the lung maturations, and in that case, if the patient requires corticosteroids, her insulin levels, insulin dose should be adjusted. Okay, so if she requires more dose of insulin and the insulin dose is increased by 25 to 40%. Also, if the patient requires tocolysis for preterm birth, it is important that you should avoid beta mimetics because they increase the susceptibility for diabetic ketoacidosis. And you should use different class of tocolysis. So which are safer tocolysis in case of DKP is atosiban and nifedipine. So it is the oxytocin receptor antagonist and calcium channel blockers. These are the safer tocolysis if it is required at all. Now to prevent the recurrence, now the patient has developed the DKP, she has been treated, and now to prevent the further recurrence, you have to educate the patient regarding how to identify and rectify the precipitating factors. Review her pre-admission diabetes control, injection technique, injection site. So whether she is taking correctly or not, whether her glucometer reliable or not, and whether she has adequate amount of insulin available with her. Okay, so the drug is available or not. Also, you have to provide the patient with contact information and further written plan of care regarding her monitoring and the fetal monitoring also. So this is the things that you should take, that you should do to prevent the recurrence of DKP. So this is the talk regarding this DKP. The important part, as I told you, is the monitoring part and the treatment protocol, that is the flow chart. Okay, so these are the questions. Type the answers in the chat box. So how long after correction of diabetic ketoacidosis would the fetal heart rate to be expected to have been normalized? I told you the answer 2-3 times here. Yes. So answer is E. It takes 4 to 8 hours to normalize the fetal heart rate tracing. Next question. I think this was the question. I don't know. Is there anyone who has given exam this time? 1 minute. No one is there. Okay. So woman with type 1 diabetes mellitus presents with suspected DKA following protracted vomiting. What is the threshold value of serum ketones to diagnose DKA? I think this was the question in this recent exam. Yes. So answer is D. It is 3 millimole per liter. So this is regarding this diabetic ketoacidosis talk. Tomorrow I'm not able to do the talk discussion. Saturday we will again meet with another talk. And I know I have forgot to give. Actually, I have not forgotten to give you the today's topics answers, but I'm not able to open that file. So I will, if in night it's possible, I will give it. Otherwise I will give you the answers tomorrow morning. Okay. So bye friends for now.
Thank you, ma'am. Thank you, ma'am.
Thank you. Bye.
Thank you, ma'am.